Yeah. Good evening, and welcome all of you to this first session this year. Happy New Year, first and foremost, to all of you, and thank you for joining on third. Last couple of months, we've had very good participation with attendees from over 40 countries. So I think we have really had a lot of encouragement. We look forward to have participation from other countries for their case presentations as well. We are having different SIGs, as you are aware, and this time the SIG is of movement disorders. So today we are going to start on understanding the movement disorders based on cases. And our experts for today are Dr. Lokesh Lingappa, who is president-elect of AOC in India, and he's a very well-known pediatric neurologist from Hyderabad Rainbow Children Hospital. And next, please. And the other expert is Dr. Naveen Sankhya, our alumnus from AIIMS New Delhi, currently heading the pediatric neurology unit at PGI Chandigarh. And thirdly, we'll also request Dr. Sangeeta, who's also our alumnus and right now as a professor in CMC Vellore, to also be an expert. And to moderate is Dr. Rachna Dubey, who again is our alumnus and a pediatric neurologist at Medanta Hospital, Indore, Madhya Pradesh. Before we start off, I will request Dr. Sangeeta to tell about the conference which is coming up next month in CMC Vellore, and then we'll hand over to Dr. Rachna for the proceedings.
Thank you, ma'am. Good evening, everyone. I wish you all a very happy and successful new year. On behalf of the organizing committee and AOCN team, I would like to extend a warm invite to all of you to attend the 14th annual conference of AOC in India, which will be held at Vellore this time, which is Vellore is also known as the fourth city of Tamil Nadu. The conference will be held from 8th to 10th of February in the Bagan campus of CMC Vellore, which is in close proximity to the ancient hills of Eastern Ghats. The conference highlights include 5 pre-conference workshops and the 2 days main conference itself, which includes cutting-edge deliberations lectures by the various national and international faculty. We also have a brilliant quiz session with exciting prizes for the winners. We have a cultural evening with gala dinner on 9th of February 2023. Please hurry up, the registrations are open. And please submit your abstracts. The last date for submission of abstract is 5th of January. We are looking forward to meeting you all at Vellore. Thank you.
Thank you, Sangeeta. Over to you, Rachna. All yours.
Thank you, ma'am. And I welcome you again. Happy New Year to all of you. And first case for today's case discussion series comes from AIIMS Rishikesh Child Neurology. Moderator being Dr. Prateek Panda, who's again AIIMS alumnus, AIIMS New Delhi alumnus, and Dr. Achanya will be the presenter. So I would request Dr. Achanya to start the presentation, and for all presenters and moderators for the case, it will be 10 minutes plus 5 minutes to give equal opportunity to everyone. So over to the first presenter. Please start sharing your screen, and Dr. Achanya.
Yes, ma'am. Is my screen visible?
Yes, definitely. Yeah.
Good evening, all. I'll be presenting a case of an adolescent girl with acute onset tremor from AIIMS Rishikesh under the guidance of Dr. Prateek Kumar Panda. We have a 16-year-old girl, Miss P, resident of Haridwar, Uttarakhand, who presented with the chief complaints of abnormal movement of the right upper limb for 1 month. This abnormal movement of the right upper limb was acute in onset, non-progressive. This movement was an excessive tremulous movement of the right upper limb, which was present distally more than proximally. This movement was present continuously on intention, action more than rest, and it increased on action and decreased on sleeping. There was no history of similar movement in other limbs or any other involuntary movements like any twisting movements. No history of emotional lability, stressors, ataxia, dysarthria, or weakness. No history of drug intake, excessive sweating, or heat intolerance. The birth history, immunization history, development history, and family history were non-contributory. On examination, she was conscious, oriented to time, place, and person, and other general examination were normal. Her vitals and anthropometry were within normal limits. On CNS examination, she was right-handed. Her higher mental functions were intact, cranial nerves were intact, the motor, the sensory system examination were normal, and there was no cerebellar signs. She had a movement disorder on examination, which is seen in this video. The child is sitting comfortably with her hands outstretched in front, which is showing a movement of the right upper limb, which is present both proximally and distally. It is a continuous oscillatory movement present along an axis with a regular rate. It is low in frequency and high in amplitude. It is predictable and lacks variation. This movement is also seen prominently and increased on keeping both hands raised in the right upper limb, and this movement is also seen both proximally and distally. As the movement was present unilaterally and it is more proximal and distal, it could have been it could be a tremor or chorea. However, the movement was continuous oscillatory movement along an axis with a regular rate, low frequency and high amplitude, which was predictable and lacked variation, and there were no spooning of hands. Hence, it is a tremor. On further characterization of the tremor, it was present at rest and was increased on intention and sustained posture. The tremor was low in frequency with a high amplitude and was central in origin, as there was no change in frequency on loading. On entrainment test, there was no change in frequency or suppression of the tremor on tapping of unaffected hand, and there was no entrainment. So in database, we have a 16-year-old girl with acute onset focal tremor, which was low in frequency, high amplitude, present at rest and increased on sustained posture and intention. So the possibilities considered were a Holmes tremor, as the child had a unilateral low frequency tremor, which was high in amplitude, present on resting, intention, and which was
just a quick thing, like, we are not able to see the video well. So I would request all the presenters to stop their videos, like, so that we can see the screen videos better. Since the internet wouldn't have been a very good bandwidth actually, right? So if you stop your video and then show the on-screen video, we'll be able to see it. Do you get what I'm saying? Yeah.
Yes, ma'am.
Okay.
Should I replay the video, ma'am?
Yes, please. We were not able to see the video. We were not able to, right?
Okay. Ma'am, is the video visible now, ma'am? Playing well?
Oh. No.
Ma'am, I'll finish my presentation and I'll open the video at the end.
Sure.
Thank you. So this tremor, on further characterization, was present at rest, increased on intention and sustained posture, had a low frequency and high in amplitude, and it was central in origin, as there was no change in frequency on loading, and on entrainment test, there was no change in frequency or suppression of tremor on tapping of unaffected hand. So the differential considered for this tremor was Holmes tremor in view of as it was unilateral, low frequency and had a high amplitude. It was present on resting, intention and on sustained posture, and it had worsened on sustained posture. As the child had an action tremor, an essential tremor was also considered as a possibility. However, these tremors were low frequency, unilateral, and there was no other movement disorder like dystonias, and it was non-progressive, and there was no non-motor symptoms like cognitive decline, apathy, etc. The other possibility considered was a Parkinsonian tremor, as there was resting tremor. However, the child had a tremor. The tremor wasn't on voluntary action. However, the Parkinsonian tremor would have suppressed. And functional tremor was also considered as a possibility, as the child had a low frequency tremor. However, the points against were there was no entrainment and no suppression during attention distraction, and no obvious stressor were identified in this child. So we had applied the Farn-Tolosa-Marin tremor scale in this child, which revealed a moderate amplitude of tremor in the right upper extremity at rest, which increased to marked amplitude on posture and intention. The handwriting showed a mildly abnormal handwriting, which was slightly untidy, and there was tremulousness seen. We had made her to draw an Archimedes spiral, where we can see that there is a slight tremulousness, and she was not crossing any lines. So we had gone ahead, we had evaluated her for possible causes of Holmes tremor like stroke or demyelination, and a CMRI brain with MRA and MRV was done, and did not show any T2 flare hyperintensities or any diffusion restriction, which ruled out stroke or demyelination as a cause. CSF autoimmune panel was done, which was negative, and for treatable causes, serum ceruloplasmin was done, which was normal, and thyroid function test and electrolytes were done, which were normal. So we had treated her with the possible first-line therapy as per literature with levodopa, on which she did not have any improvement in the tremors, and we had also started her on trihexyphenidyl. The tremor did not improve on the tremor scale. Hence, we went ahead with the second line treatment like clonazepam. And she's on follow-up, and our plan is to do a surface EMG on follow-up. And if there is no improvement on the tremor scale, we may also consider the other treatment options and other treatment options like deep brain stimulation as well on further follow-up. So, in take-home messages, in a case of acute onset focal tremor, a possibility of Holmes tremor must be considered, and management of Holmes tremor remains challenging, with partially treatment noted with pharmacological therapy. Thank you.
Thank you, Achanya. So we have 1 minute, I should say half a minute. So if Dr. Panda has to add anything, because he's the moderator for this case.
Good evening, ma'am. Am I audible, ma'am?
Yes, yes.
Ma'am, we thought of mainly initially functional tremor or some, but it was looking like more of a Holmes tremor. It was recalcitrant. Only thing I wanted to know, since most of the medications are not working in this case, especially we don't have an option of deep brain stimulation or any such intervention in our center, ma'am. So we could send to somewhere places like AIIMS Delhi or PGI Chandigarh for this child. She has exam coming up in March, so it would have been a more helpful. That is the only thing.
Right. So Dr. Naveen, to comment on the case.
Thank you. It was a very interesting case, and thank you, Achanya, for presenting it within the time allotted. It's a rather interesting and unusual cause for tremor in children. So I personally don't have much experience in treating Holmes tremor. But it is said that it normally would increase with a lot of stressors, and including the use of stimulants and psychological stress. So have we looked at that aspect in this patient? That is my first question. Secondly, would you be happy with excluding Wilson's disease with a ceruloplasmin, or a 24-hour urine copper is also in order in this patient? Because in many patients with tremor at this age, tremor can be the first sign of Wilson's disease as well. As far as treatment goes, I think as for many other movement disorders, it is you don't know really at the outset as to which drug is going to be effective in what patient, and one has to really try sequentially one after another. DBS would be, I think, a little drastic option for if it is not a very impairing tremor at the moment. And one may try oral drugs initially and then follow it up with the family whether they really wish to have such an expensive procedure for a tremor. So that is my take. And if Dr. Meek or Achanya can add to what they have already said, it will be nice.
I could just make one comment. I mean, we happened to see one Rubral and Holmes tremor similar, and it was a red nucleus involvement by a cavernoma, small cavernoma. And the radiosurgery stereotactic was excellent, and that works very well. And that is the time we tried to review, what medications can help. So levetiracetam was also one of those which could help in rubral tremor. So this is just the limited experience, but I should say if it is lesional, then yes, radiosurgery is excellent.
Yes, I think that's a good suggestion.
Lokesh, can you speak? Dr. Lokesh, I know you're driving. If you can, you speak, otherwise Sangeeta. Krishna, I think you can ask Sangeeta.
Yes. Dr. Sangeeta, to add anything, because these cases are really rare. So if there is anything which she's come across and can add up to the things.
Yeah, thanks, Dr. Achanya and Dr. Pratik for the interesting case. As Naveen sir was mentioning, it's not the usual cause of tremor that we often encounter in the pediatric neurology practice. So as a learning point, like any child with an unexplained movement disorder towards the end of the first decade or later, workup for Wilson's disease is definitely mandatory. The Holmes tremor is usually associated with some midbrain lesions. So as Dr. Achana was mentioning, it's always better to have an imaging to look for any underlying tumors or any vascular lesions, or it could be associated sometimes with infections as well. So it's an interesting case. Thanks, Dr. Achanya.
So thank you, everyone. We should move on to the second case, which comes from GNMC Belgavi, and Dr. Mahesh Kamathe is moderator for this, and Dr. Gayatri Pawar will be presenting. So moving on to the second case presentation. Over to Dr. Gayatri.
Dr.
Yes.
Rachna, if I may interrupt, can we have a look at the video again if it is possible for the first?
Yes, definitely, because that will be very unique as Holmes tremors. It's very, very unique video. So
Yes, ma'am. Yes, ma'am. I'll play the video.
Dr. Achanya, if we can see the video, yes.
Yes, ma'am.
Keep your video off. Keep your own video off because you are anyway having a red bar for your connectivity.
So all the other presenters also, I would request if we can keep the video off, because for movement disorder, if we are not able to see a good quality video, then for people who have not seen rubral tremor, I guess that's the most important thing over here.
Ma'am, is the video visible now?
You have to play it. We can see the file open. Can you play the video?
Yes, ma'am. I'm playing the video.
Hello. Dr. Rachana, you can play the video from your presentation.
Okay. Is the video visible now, ma'am? Is it playing now?
I don't see it.
I think Chanya, you stop sharing the screen. Send it to send this the slide, the video to Asmita, and Asmita will share it after the next case. Okay, right?
Yes,
And
ma'am.
thank you for presenting it very well. Your certificate will be mailed to you, but you please send it to Asmita. Asmita, you can chat on the send your email on the personalized chat. Yeah.
Yes.
Can I share the same video? Can I share the same video?
You share. Pratik, please make Pratik the co-host. Yeah, fine, Pratik.
I think the video is
Yeah,
visible for.
it's visible. It's visible very
Ma'am,
much.
it is only one of the videos. So
Hmm.
it is showing the mainly the postural part, ma'am. The resting part is not in this video, but
Mhm.
we can see that it is a low frequency and high amplitude tremor, predominantly involving distal more than proximal, and only one upper limb is involved. That is the right upper limb. And the other maneuvers and other videos, I think Achanya will mail. I can play this again.
Yeah, so perfect. So key things are like, postural, kinetic, intentional. All the time you will be seeing this, predominantly distal. And as we can see, asymmetry on the right, almost focal. So, yeah,
Thank you.
thank you. Can stop
Like
sharing.
can you see the questions also in the chat and take it simultaneously?
Yes, ma'am. I don't see any. Yeah.
Something in the chat there.
Does not appear to be like Holmes. Kalpana Dev. Kalpana.
Dr.
So
Tajul has also asked.
yes, it is a high frequency, low amplitude tremor, unilateral, think of psychogenic. So Dr. Tajul's suggestion does not appear to be Holmes, and this is not Holmes. So I guess, yes, I mean, when you see the video, yes.
1 second, Asmita, please upgrade Dr. Tajul to the panelist, please. Yeah, and Tajul, you please accept the
Yes.
upgradation. Yeah. Please continue.
So I guess,
Please continue.
yeah, we can ask Dr. Tajul to comment upon, and I do agree to what they're saying. I guess the whole thing depends on whether we have tested it in all things and how well it has been tested, and its video is depicting all those. So I guess those things are being questioned. So maybe we can ask Dr. Tajul to comment if he's already.
Yeah, he's there. Yeah, he's joined on panelist. Yeah. Dr. Tajul, thanks for joining.
Hi. Can you all hear me?
Yes.
Yeah.
Yeah. So my video, I think it's not working, but it's okay. So anyway, the tremor that was shown in the video, I mean, we were able to see it in the second time as the video was played. It's rather slightly high frequency and low amplitude, very much distal. It's very predictable. It's around the joint. So it is tremor. Phenomenologically, it's tremor. But for you to have a unilateral, what do you call high frequency, low amplitude tremor, you probably need to think of something very much more psychogenic. So it's definitely not rubral or Holmes. Rubral or Holmes tremor is something that people have been always suspecting originating from brainstem region. It's very erratic. It's always triggered or it's always worsened by certain actions or certain posturing. So it's definitely not Holmes. This is a very much more regular tremor. So maybe certain movements or certain what we call acts may be able to give us slightly more information of the characteristic of the tremor. Now, of course, it will be also useful to see if the tremor is what we call sustained during resting, sustenance, and more action to clearly identify if this is a kinetic tremor or just purely an action tremor.
So I just tried to take out the rubral tremor video, which I was discussing, the focal cavernoma. So maybe at the end of it, if we have time, I would be able to share that video. Just
Sure.
to say that this is what is rubral tremor. Yeah.
Yes. Thank you.
Yeah. So
you can take it out and have it after the next case because it will be fresh in people's mind. Yeah.
Sure. So we go on to the second presentation. So Dr. Gayatri to start her presentation, please.
Yes, ma'am. Am I audible and visible, ma'am?
Yes, yes. Yeah.
Okay. Good evening, everyone. I'm Dr. Gayatri Pawar, a DM Pediatric Neurology resident from JNMC, Belagavi. I'll be presenting a less recognized movement disorder in children under the guidance of Dr. Mahesh Kamte, sir. We had a 18-year-old girl with normal birth history and development who was brought to us with chief complaints of generalized seizures for 10 days, abnormal behavior for 10 days, and altered sensorium for 6 days. Following first episode of seizure, she was dull, lethargic, had reduced speech and disturbed sleep. She was seizure-free for next 3 days. On day 4 of illness, there was status epilepticus. She was hospitalized, was loaded with 3 consecutive anti-seizure medications, and she was referred to us for further management. There was history of fever 20 days prior to the onset of illness. The following movement abnormalities were noted. So in the first video, you can see that there is rhythmic extension of right thumb and index finger at metacarpophalangeal joint, and these movements could not be restrained. In the second video, you can see that there is relatively rhythmic slight flexion movements of right elbow, and these movements persisted for few minutes to more than an hour. The movements rate was less than an or equal to 1 Hertz. They were relatively rhythmic, confined to hands and elbow, with large amplitude, similar pattern, intermittent or continual, occurring at rest with impaired sensorium. It was not drug related, and these movement lasted for about 4 to 5 days. So in the third video, in this video, you can see that there is somewhat arrhythmic extension and flexion at wrist with asymmetric involvement of fingers at metacarpophalangeal joints. In the next video, you can see that there is rhythmic contraction of upper facial muscles, mainly the procerus and corrugator supercilii. On examination, there was dysautonomia noted. She was mute. There was no response to painful stimulus. She had intact brainstem reflexes and good sleep-wake cycle. Focal limb dystonia was noted. Oromotor dyskinesias were noted. There was reduced tone in all 4 limbs with power more than 3/5 in all 4 limbs with depressed deep tendon reflexes. With a background of altered sensorium and behavioral changes with insomnia, seizures, movement abnormalities, and with infection trigger, we thought of post-infectious autoimmune encephalitis, query NMDR encephalitis. So we went ahead with investigations where CSF analysis showed 18 cells, more than 90% being lymphocytes with normal sugar and proteins. MRI brain was normal. EEG showed bihemispheric slowing. We sent CSF NMDAR receptor antibody, which was strongly positive. CT abdomen was done. There was no ovarian mass or teratoma. So differentials for the movement that we saw. Was it dystonia? Unlikely because there was no classical twisting or sustained posture. Was it stereotypy? Again, unlikely because it was not that distractible. Not myoclonus because there was no typical jerk-like movement. Neither it was like a tremor because it was of high amplitude and was a slower movement. So we did literature review to look for similar movement abnormality, and we came across this term myorhythmia, which is reported in NMDR encephalitis in children, and the reports are very few. So with the description, a stereotypy is a non-goal-directed movement or vocalization pattern that is repeated continually for a period of time in the same form and on multiple occasions and is typically distractible. Whereas myoclonic jerks are sudden, brief, shock-like involuntary movements caused by muscular contractions, that is, can be positive myoclonus or inhibitions causing negative myoclonus. Tremor is a rhythmic oscillatory movement produced by alternating or simultaneous contraction of agonist and antagonist muscles, whereas myorhythmia is a slow 1 to 4 Hz prolonged, continuous or intermittent, relatively rhythmic, repetitive movement occurring mainly at rest typically affecting cranial and limb muscles. So, points favoring stereotypy where though it was repetitive and occurring in same fashion, it was not distractible. For myoclonus, rhythmic and repetitive being points for, whereas points against where there was no jerky component. For tremor, though relatively oscillatory, this was low frequency and high amplitude, so there were points against. For myorhythmia, it was slow, relatively rhythmic, repetitive, continuous or intermittent, and involving face and limb. And though some points like less than 1 Hertz and arrhythmic at few instances, most of the points were fitting into myorhythmia. So our final diagnosis was autoimmune anti-NMDAR encephalitis with epileptic seizures, with mutism and insomnia, with movement abnormalities like myorhythmia, dystonia, and oromotor dyskinesias. So we treated her with 5 days of methylprednisolone pulse therapy, injection rituximab, 2 doses 1 week apart, tap tofacitinib, second pulse of methylprednisolone was also considered due to poor response. Artifeeds, physiotherapy, clonidine, and baclofen and anti-seizure medications were considered. Her duration of hospital stay was 3 weeks. At discharge, she had good eye contact. She was mute, non-ambulant. Spontaneous limb movements were noted with oromotor dyskinesias, and there was no dysautonomia. Myorhythmia lasted for 4 days from the onset, and it was absent at discharge. EMG was not done in our case to conclude the movement. So myorhythmia, it is a unique, repetitive, rhythmic, slow 1 to 4 Hertz movement occurring mainly at rest, typically affecting cranial and limb muscles. The term was introduced by Hertz in 1931, who described it as a repetitive, slow 1 to 4 Hertz movement seen chiefly in patients with dystonia, first used in reference to Whipple's disease in adults. These movements typically occur at rest but may be observed during maintenance of posture and with voluntary activity, usually disappearing during sleep. The movement is produced by alternating or synchronous contractions of antagonist muscles. Oculomasticatory myorhythmia is a form of cranial myorhythmia, which is slow 1 to 3 Hertz, repetitive, often asymmetrical facial and ocular involvement, is characteristically present in Whipple's disease. It may be accompanied by 1 to 3 Hertz convergent or divergent pendular or vertical nystagmus, rhythmic eye opening and closing, tongue protrusion or retraction, bruxism, and synchronous contraction of facial and masticatory muscles. It should be distinguished from variety of movement disorders affecting the facial muscles, including hemifacial spasm, facial tics, myoclonus, dystonia, and psychogenic movements. Palatal myoclonus or segmental myoclonus may be associated with myorhythmia. Anatomical correlates of myorhythmia is quite heterogeneous. Involvement of anatomical components of Gillian-Mollaret triangle involving dentate nucleus, superior cerebellar peduncle, red nucleus, and inferior olive is thought. Substantia nigra may also play a role. It is commonly reported with anti-NMDR encephalitis in children, though pediatric case reports with myorhythmia are very rare. Case reports in CVA are mainly present in older age group like 60 to 75 years. Other causes being infectious, as I told, Whipple's disease in adults, Listeria encephalitis, paraneoplastic like Hodgkin's squamous cell carcinoma, multiple sclerosis, head trauma, degenerative disorders, hereditary X-linked dystonia, Parkinsonism, and drugs like phenytoin intoxication can cause it. EMG characteristically shows discharges of motor units with normal morphology with a slow 1 to 4 Hertz interburst rate. Symptomatic treatment of myorhythmia is usually ineffective. The following drugs have limited or no efficacy like baclofen, benztropine, carbamazepine, clonazepam, diazepam, levodopa, lorazepam, trihexyphenidyl, haloperidol, fluoxetine, vigabatrin, and tetrabenazine have been tried. Myorhythmia associated with anti-NMDA receptor encephalitis improves with tetrabenazine and immunotherapy, including plasmapheresis, IVIG, corticosteroids, and rituximab. So to conclude, myorhythmia is less seen in pediatric age group and is also less recognized. Its phenomenology is important to recognize because it usually gives clue to the underlying etiology. Treatment directed at underlying cause can abort the movement or it can have spontaneous resolution. Thank you.
So thank you, Gayatri.
Thank you.
And that was very well presented and very informative and unique. I would ask Dr. Mahesh if he has to sum up our comment, and then finally the experts. Yes.
This is a case of autoimmune encephalitis who had this peculiar type of movement disorders. And initial few days, even we had difficulty in characterizing this movement. It didn't fit into our typical known disorders like dystonia, tremor, agitation, and myoclonus. So we are thinking, hey, like, what is this type of movement? And we did literature review. We did come across this term myorhythmia. Though myorhythmia is a term which is well known in movement disorder specialists, it's not that commonly recognized and discussed by pediatric neurologists. And we had to do a literature review, and this child typically fit into that term myorhythmia. After that, we have seen such movement in another one case who also had seronegative autoimmune encephalitis. So I think this can be a marker for underlying autoimmune encephalitis in children. There is no specific treatment for this, but recognition can really. Thank you.
Thank you. So, Dr. Naveen, to make comments.
I would agree with Dr. Mahesh's observation that this is an under-recognized movement disorder, but it does give a clue to presence of underlying autoimmune encephalitis. I have seen this in children as well as a few adult cases as well. And this was one of the initial movement disorder which was recognized to be specific for NMDA also. Not entirely specific, but common in NMDA. And the thing is that this gets confused with stereotypy because both are patterned, repetitive, similar movement occurring again and again. So it's a very interesting case. Thank you, Dr. Mahesh. And I would also like to listen to what Dr. Taj has to say on this. But I personally think that it's important to recognize this as a unique movement disorder, which gives a clue to underlying autoimmune encephalitis. Thank you.
Yes, thank you, Naveen. I mean, phenomenologically, probably it would be a mixture of a few phenomenology. And to say classically myorhythmia, of course, this is something that was dedicated to Whipple disease and the characteristics of slow, rhythmic 1 to 4 hertz movement to be called or denoted as myorhythmia. I think certain forms of movements that we see in certain diseases or certain illness may not fit into a single criteria of any phenomenology that we are very familiarized with. So sometimes, like, for example, in anti-NMDR and certain forms of seronegative autoimmune encephalitis, we do see this orobuccolingual, sometimes masticatory dyskinesias, which may not fit into either stereotypies or tremors or certain forms of myoclonus. But if you look at the what you call myorhythmias that you do see in Whipple's disease, they may be in certain forms characterized as segmental distal myoclonuses, but they're not as rapid, but they're very rhythmic myoclonuses. And the EMG does what you call fit into a characteristic for rhythmic myoclonus. Hence, sometimes one of the lessons to learn here is not every movement disorders we tend to see can fit into a certain phenomenology. Sometimes it may be a mixture. So, for example, in the video of that girl, none of the movements were characteristic can be denoted as characteristically something very rhythmic. Most of them were non-rhythmic, but they were repetitive. They were irregularly repetitive. And the left hand movement was more of a posturing rather than a pure hyperkinetic movement. So to clearly classify as what you call myorhythmia possible in certain forms or certain times, but not at all times. So trying to what you call diagnose them or trying to fit them into one phenomenology may sometimes be proved non-fruitful in certain cases, like especially in autoimmune encephalitis or in cases where the phenomenology may change from one phenotype to another phenotype. Thank you.
Thank you so much. So do we move on to the next case? Or should I show the Rubral video? So
You can show the video, I think.
Okay. So I should be sharing my screen if I have to ask Asmita.
You can share, ma'am.
Okay. Is it visible?
Yeah.
So this was the patient which I was talking about. She had cavernoma, and we can see the left side continuously moving. So classically, we are testing her for resting and also for action. So unfortunately, you can see the resting over here. We are checking for intention and postural. So since she is also not using that side very well, so I guess this is the one where the structural leading to the rubral, and this was totally treated with surgical radiosurgery treatment over here, gamma knife. Thank you. Dr. Tajul, I mean, does that look like rubral?
Yeah, that's definitely a rubral tremor. Large amplitude, irregular, keeps changing, erratic in nature. Certain postures changes the characteristics, even the frequency and the amplitude of the tremor, and even the segmental involvement of the tremor evolves with certain postures and certain movement. That is rubral tremor. The unpredictability and the erraticness is the clue for a rubral tremor. They're quite large amplitude. They're never small amplitude tremors. Yes.
Let's move on to our third case for the day. That's Dr. Yatwin will be presenting. And this comes from SRMC Chennai. Dr. Ranjit Kumar Manokaran will be moderator for this case. So please share your screen for the presentation.
Excuse me, ma'am. Am I visible?
Yeah, please make it to the slideshow.
Oh, yeah, just a moment, ma'am.
Audible and visible, yes. Presentation, slide presentation. Yeah.
Can you see now?
Yes, perfect. Please start.
Hi, my name is Yatwin. I'm a fourth year MBA student at Sri Ramachandra Institute of Higher Education and Research. I'm here to present a case of tick status continua in a 16-year-old girl with guidance from Dr. Ranjit. Case history. A 16-year-old girl presented with continuous blinking involving both eyes with blepharospasm and discomfort of the left eye, which were preceded by an episode of fever 3 weeks ago. No abnormal findings were found on systemic examination except for the persistent ocular symptoms. There was no significant family or birth history. The symptoms were causing significant anxiety and discomfort to the patient and her family. And important history would be her brother died due to accidental drowning 6 months ago, which could be a differential for a functional form of tics in our patient. So here I have a video of the patient actually demonstrating the ocular symptoms. So you can see she's having uh, a continuous form of blinking with the blepharospasm of the left eye. And as the video goes, we asked her to look upwards or sideways. At that point, the tics became more prominent and explosive in nature, as you will see now. Here we are asking her to close her eyes, try to close her eyes as tightly as possible. And here we are asking her to look upwards and then sideways later on. You can see the tics is becoming more prominent. I'll be proceeding further. So on a focused examination, we saw her general examination was normal, higher mental functions were normal, motor and cranial nerve functions did not show any abnormality, ocular exam did not show any ophthalmoplegia, the pupils were reactive and the fundus was normal, cerebral sensory system was normal, no meningeal signs of irritation. The eye blinking was continuous and causing significant distress, present during sleep as well as during pseudo sleep. The differential diagnosis we had for the phenomenology. The differentials we considered were eyelid myoclonia, primary tic disorder or Tourette syndrome, ocular tics or blepharospasm of post-infectious inflammatory or autoimmune etiology, functional or psychological tics, and malingering. On evaluation, the blood counts of the patient was normal. Electroencephalogram was normal except for the continuous eye blink artifacts. Magnificent resonant imaging of the brain was also normal. Erythrocyte sedimentation rate was mildly elevated of 18 mm per hour. The biological reference value would be 0 to 15 mm per hour. Fundus examination was normal, refraction was normal, and the psychological assessment was also normal. Based on the findings above, what do you think could be the etiology for this patient? If there are no answers, I will proceed further now.
I'm checking. I don't see this. I mean, someone has asked for EEG for this patient.
The EEG was normal except for the continuous eye blink artifact, so we did not include the image.
Okay. So no suggestions, so you can proceed.
Yes, ma'am. On further evaluation, the anti-streptococcal titer was elevated of the range 1070 international units per ml. The biological reference value would be less than 200 international units per ml. It was repeated once again shortly after for confirmation, and it was again 1170 international units per ml. The throat swab culture did not show any growth, and based on modified Jones criteria, no clinical evidence of rheumatic fever were found. Echo and ECG were also normal for this patient. So here you have the diagnostic criteria for a pediatric acute onset neuropsychiatric syndrome and pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. So we immediately ruled out PANS in view that the patient did not have any obsessive compulsive disorder or any of these behavioral symptoms. But as far as PANDAS is concerned, the patient fulfilled all the criteria except for the age requirement. As our patient is 16 years old, she did not meet this criteria, but otherwise she had an unusual form of tics, which was of acute onset and associated with a group A streptococcal infection, as by the anti-streptococcal titer. And for a neurological manifestation as well, she had a blepharospasm. So it was a incompletely formed PANDAS criteria. The final diagnosis we had for the patient was a post-streptococcal tics with blepharospasm. For the management, the patient was started on oral clonidine and clonazepam for the first 3 days. After 3 days of clonidine and clonazepam, there was only mild improvement. After making diagnosis of post-streptococcal tics disorder, she was started on injectable methylprednisolone in a pulsatile manner of 30 mg per kg per day for the next 5 days. Within 4 days of IV steroids, there was complete symptomatic resolution, as I will show you in the video. So here you have the video of the patient having the tics again, so that you can see how significant the symptomatic relief would be later on.
What is your name? Close your eyes more tightly. Open. Okay. Show your tongue. Okay, close. Open your eyes as much as you can, like. Okay, see towards this side. Only the eyes, only the eyes. Okay, straight.
Here you can see this is the patient 4 days after the treatment. And you can see she has had complete symptomatic relief.
How are you feeling now? Are you going to school?
So for the discussion, the association between streptococcal infections and movement disorders like tics has been described, but continues to be a much debated subject. Autoantibodies against striatal cholinergic interneurons have been implicated in the pathophysiology of tics after streptococcal infection. Based on a literature review, cases of continuous tics with blepharospasm have not yet been reported, and the immediate resolution of symptoms with steroids hints towards an autoimmune pathology in our case. For conclusion, post-infectious or post-streptococcal phenomena should be kept in the differential diagnosis in any typically developing pre-morbidly normal child who presents with new acute onset movement disorders, including tics. They usually respond very well to immunotherapy, and successful treatment relieved our patient of her symptoms, which were very distressful and were affecting her quality of life. On follow-up 1 month later, steroids, clonidine, and clonazepam all had been tapered off, and she's been doing well. For the take-home message, post-infectious or post-streptococcal phenomena is a treatable autoimmune condition and should not be missed. These are my references. Thank you.
Thank you so much, Yathwin. I would request now Ranjit to add up, though we could hear a lot of his comments in the videos itself. So over to Dr. Ranjit.
Good evening, ma'am. Thank you for giving us opportunity to present. First of all, I would like to congratulate Yathwin. He's a MBBS student among the DM students who is presenting today. So this case was referred to us as eyelid myoclonic status. So the first thing we did was doing a video EEG and ruling out continuous kind of a seizure, which can present sometimes as a myoclonic status, which was not the case here. Then we thought it could be functional or not, but it was continuous, persistent, associated with a painful blepharospasm on the left, so which is like clinically against a functional possibility. And we ruled out common other structural problems as well. And ASO titer was elevated, and it was repeated again to make sure is it kind of a one-of-a-kind spurious report? No, it was elevated twice with mild ESR elevation. And following that, we gave her immunotherapy, to which she responded very well. So I would like to hear more comments about the phenomenology, but we coined it as continuous tics, and this is a term from ChatGPT, tic status continua. So happy to hear some other terms as well. Yeah.
So I would ask Dr. Naveen to comment first, and let's hear what he has to say on this.
Well, thank you, Ranjit. The most important thing is that the child was fine after you treated the child. I just had a few questions first. I mean, was the child able to suppress these movements for any bit, or was there was any fluctuation in the symptoms? Second thing is, whatever video we saw, we didn't see any ocular movement. It was limited to the lids. And I felt that the right side also was partly closed. It was not just left-sided blepharospasm, so to say, but also the right-sided. So if you could clarify these points. And third, one more question is whether she had secondary effects on the lids, because if somebody involuntarily keeps on pressing the lids like this, there may be secondary lid swelling. So was there any of this seen?
Yes, sir. So it was continuous, sir. Like almost like except during deep sleep, it was continuous. So we couldn't see any fluctuation. Only when we asked her to move her eyes up or on the sideways, it was of higher frequency. But otherwise, it was continuous. And we didn't see any kind of a swelling or anything like secondary to this. So that's the thing. And as you said, like eye movements were well preserved, and there was only eye blink, continuous eye blink. So,
Okay. Eyelid. So because one thought when I see this child is certainly that it is a somatization, because somatization can come in various forms. And we know that hospitalization and intervention with drugs can also have a dramatic effect on their phenomenology. But since you have followed this patient up, you would know better whether the patient had any psychogenic stress or any other risk factors for having this kind of phenomenology. But that is my closest differential that I would consider in this patient.
Thank you. Thank you so much. So Dr. Tajul, to comment on the movement and phenomenology. And
Yeah, thank you again. Good case presentation. Congratulations to the medical student. I wish I was as smart as him when I was a medical student. As far as phenomenology is concerned, I think we have to be a bit very careful when we denote a certain child as having tic disorders, because as far as phenomenology is concerned, probably we don't have enough information to call this as a tic. It's something very continuous, very repetitive, high frequency, small amplitude, irregular, jerky movements of the eyelids, and probably minimal ocular movement. So probably eyelid myoclonia or oculomyoclonia, one of these genera would probably fit the phenomenology. Something in the sense of rhythmic myoclonus or myoclonic tremor. That would be the phenomenology itself. Probably tick would not best what they call satisfy the criteria. The question would also be, as Dr. Naveen has asked, is the child able to suppress? Which from the video it does not look as a case where the child could suppress. The second question would be, was the movement persistent when the child was sleeping? And the third, did the nature of these movements change at different situations, environment, different acts? So if it did not change and it persisted in sleep, I mean, that would be also very interesting to know. Probably not really suggestive of tics. It'd be very difficult for me to squeeze this phenomenology into the tic disorder, which is most of the times partially suppressible and not continuous. Second comment would be the SOT titer. So any Asian will have a high streptococcal titer at some point of time. So for us to jump on the gun and say that this is too much, I mean, this is very significant and etiologically significant, also be sometimes a bit more hazardous. So the fourth would be, it doesn't satisfy the criteria for PANS and PANDAS. I wouldn't call these PANS, I wouldn't call these PANDAS, because there should be predominant or significant neuropsychiatric manifestation rather than a movement disorder, because the entire what they call aim of coining PANS was to slightly include certain cases that do not fit into PANDAS, which was by what they call Harvey and also John in I think about 10 years ago, when they found that many cases do resemble PANDAS, but they do not have the pre-existing streptococcal infection, as Professor Swido coined in 1997. So the neuropsychiatric manifestation is something that plays a huge burden in making a diagnosis of PANS and PANDAS. So without that, I probably wouldn't coin them into PANS and PANDAS. But yes, I've seen a few cases with this, almost similar to this. Some of them disappear by themselves. They are essential ocular myochemias. But I've seen two or three cases, if I'm not mistaken, which were caused by brainstem irritation, either by demyelination. I had two cases where multiple sclerosis were presented with such phenomena. The other one was, something I suspected post-infectious, couldn't find anything in the MRI, but responded to steroids. All three of these patients responded to steroids. So I suspect there might be something in the MRI or something which is of demyelinating in nature or irritating the brainstem, but maybe MRI positive or not positive, maybe MRI negative. Thank you.
Thank you so much, Dr. Tajul. So, Dr. Ranjit, to clarify on the MRI and demyelination, and Dr. Tajul and Dr. Naveen's comments, please.
Yes, ma'am. Her MRI was normal. So it was an MRI brain with contrast. And sleep what was very tricky. Like actually it persisted even during the early phase of the sleep. So we tried to take videos at night also. We were not sure what happened during a deep sleep stage in her. And the response to steroids was quite dramatic. Like day 3, we can see a steady kind of a response. On day 3, there was a significant response. On day 4, it completely went to a halt, almost like 95%. So we could see she was responding to steroids. Whether it was a kind of a response, as Dr. Tajul was saying, to post-infectious phenomena, we are not sure of that. But definitely there was no suppressibility. She couldn't voluntarily suppress on her own. She clearly expressed the pain due to the blepharospasm, and we clinically try to pull the orbicularis oculi. We can see the tightness. We can feel the tightness. So I don't think it is functional.
So hence, this is not a tic disorder, because there is a tonic spasm of the muscle groups, as you have demonstrated by physically trying to elevate, going against the movement itself. Whereas, although tic disorders, they are not supposed to be rhythmic, there is a certain form of rhythmicity in what you call in its characteristic. So this is more of a muscle spasm. So it would better fit into blepharospasm or, oculomyokemias. I mean, eyelid myokemias and oculomyokemias. Yep.
So
Thanks,
thank you
Dr.
so much.
Raju. Yeah.
Thank you so much for the expert inputs. And actually, it's turning out to be truly a case discussion in true sense, as we have seen in 2 cases at least. So moving on to case 4, which comes from AIMS New Delhi. Dr. Gautam Kamila is moderator, and Dr. Akash will be presenting this. So Dr. Akash, to present your case, please.
Is my screen visible, ma'am?
Yes.
Okay. Good evening, everyone. Today I will be showing a series of 3 cases, all the 3 having the same movement disorder, diaphragmatic flutter, but each one having a different etiology and a different presentation. So we'll straight away move on to the movements per se. So I want to focus on the epigastric region on all the 3 cases. So this is the first case. So we can see near the epigastric region, there is some sudden rapid jerky movements happening, which is restricted to the upper abdominal wall, and it is spontaneous, not stimulus sensitive, around 30 to 40 per minute. And there was little decrease in the frequency with breath holding, but it did not affect respiration. There was no suppressibility or distractibility, but it was subsiding with sleep, and there was no other neurological signs. So in the second case, so here we can see a more clearer movements happening. So this here, the child is having much higher frequency up to 180 to 240 times per minute. So restricted to the upper abdomen. And in the third case, so here the movement is happening in the left upper quadrant. So this is also a focal rapid jerking movement, and it is also happening more than 100 per minute. The one thing which is not seen in this video is that child also had other neurological signs, dystonia and weakness at presentation. So any movement with this presentation in this region, so we will have the differentials of a hiccup, but it will have a forceful laryngeal closure producing that hic sound component to it. For propiospinal myoclonus, it's a lower frequency movement disorder with involvement of both the neck and the trunk also coming together like a spasm, and diaphragmatic myoclonus of flutters. Palpitation, this is not the exact anatomical region for that, and dystonias, there should be some sustained contractions. So most likely would be a diaphragmatic myoclonus or flutters. So coming to the presentation of these 3 cases, first one was a chronic case. So the child had presented with a 4-month history without any other accompanying significant histories. And second case was a very acute presentation, presenting in the past 12 hours only. And on examination, she had signs of hypocalcemia. So Chvostek sign was present. And third case was a subacute onset. The child had a history for the past 12 days only. So there was a febrile illness which triggered seizure, some regression, weakness, loss of ambulation, and extrapyramidal movements, dystonia with encephalopathy. So investigation wise, first child, we did an ultrasound abdomen which showed diaphragmatic flutters. I'll be coming to the video later. So second case, hypocalcemia was confirmed with low parathyroid hormone. Third case, so since the child had seizures and encephalopathy localizing to the gray matter, we did an MRI. So it is showing bilateral basal ganglia, hyperintensity, which is also little swollen. Other investigations, infective, metabolic, and autoimmune panels were negative. So differentials, first one was idiopathic diaphragmatic flutters, but psychogenic will always be another part of that. So second one was hypocalcemia-induced diaphragmatic flutters. And third, we had differentials ranging from autoimmune to neurometabolic causes, including biotin thiamine responsive basal ganglia disorders. So treatment-wise, first one we started with clonazepam, and the movements gradually reduced and stopped. Second one, with calcium correction, it stopped immediately. For the third case, we had empirically started on biotin and thiamine. We had ruled out autoimmune encephalitis and other basic metabolic workup. The patient couldn't work up genetic panel. So with the biotin thiamine itself, the patient started showing response, and he was all right till 2 months of follow-up. So empirically was kept as biotin thiamine response reducer. So we have 3 different etiologies having the same presentation of diaphragmatic flutters. So one had a chronic onset, one had a hyperacute onset, one had a subacute onset. So one had a relative lower frequency, another higher, other two the higher frequency. So all the 3 having rapid jerky movements. So they were not suppressible, they were not distractible. So they were mostly suggestive of a myoclonic type of movements happening in the diaphragmatic region. So anatomically localizing of diaphragmatic flutters could be either peripheral or subcortical, mainly the dentator rubro-olivary tract triangle. And it can present with either epigastric pain or as palpitations or dyspnea commonly. Other synonym would be a belly dancer's dyskinesia. So central causes, as we had seen in that our case, we had a metabolic cause. Peripheral cases could be pleurisy or pericarditis irritating the vagal nerve. Hypocalcemia is one of the rarest causes. So investigation-wise, ideally we will need a EMG to confirm, and an EG EMG back averaged setup would be able to confirm or differentiate between an idiopathic and a functional one, which we were not able to do. So drugs, usually clonazepam, work well with the idiopathic cases, and phenytoin and other sodium channel blockers usually work well with peripheral myoclonus. So if it is a central cause, they may not work well. And final result would be phrenic nerve crushing. So this was another case which had come recently. So the child is currently keeping the breath still. So here we can see the movement happening above and the M mode in the ultrasound with the corresponding movement showing the diaphragmatic excursions. So this is one way of showing diaphragmatic flutters using the ultrasound. Thank you.
Thank you so much. That was very interesting case series and very unique. I would request Dr. Prashant to sum up as a moderator. Dr. Prashant Jovi.
Yeah, ma'am,
Dr. Kamala, yes, I'm sorry.
so this presentation was just to highlight regarding the rare kind of movement disorder, like showing 3 cases of diaphragmatic flutter. So we all know that basically this is a form of myoclonus. So the key point is to first observe the movement which is occurring at presentation and describing the phenomenology of the movement, like in the form of the localization, amplitude, repetition, rhythmicity, and distractibility and all. And that will help us in narrowing down the differentials. And in this particular case, as you can see that ultrasound is a very simple modality to make a diagnosis in this particular case. So that is about this particular series.
So I can see one comment from Dr. Sangeeta. So she's saying, was there any mammillary body involvement in third case? And was there any setting for Wernicke's encephalopathy? Because too dramatic response for biotin response basal ganglia disease.
No such abnormality was detected in the MRI.
Okay. And Dr. Tajul for comments for hiccup and such movements.
I think they're all good cases, not much of comments. Most of them, spinal myoclonus sometimes can be very difficult to diagnose, and as is mentioned, etiologically variable. But the interesting case was the third case, because the involvement was the head of caudate and putamen, but presenting with abdominal myoclonus or the diaphragmatic flutter. That's a bit interesting. There's a possibility that some of the nigrostriatal pathways which are connected to the brainstem input, also the cerebral input, could have been involved. But that's interesting, unless this patient also has got some form of missed spinal cord involvement or some spinal cord lesion or spinal cord demyelination or edema. Because most of the diaphragmatic flutters or diaphragmatic myoclonus, abdominal myoclonus, which could be involving the rectus abdominis itself or could be secondary to the diaphragmatic movement, they are propiospinal in nature. They're segmental myoclonus originating from the autonomous generators of the spinal motor neurons rather than something which is more central in nature. So that's very interesting for basal ganglia involvement to what they call result in abdominal myoclonus or what they call diaphragmatic flutter. That's quite interesting. It'll be worthwhile probably looking at the spinal cord, thin slice spinal cord, probably 2 millimeter, 3 Tesla MRIs to see if there's any small lesions there, which we probably could have missed. And of course, psychogenic is another common psychogenic motor tics, common diagnosis for this what you call diaphragmatic flutter or abdominal myoclonus.
And
Thank you.
also patients who have progressive myoclonic epilepsy, lipofuscinosis, they also have sometimes these segmental abdominal movements. So where do we place them? I mean, that also will come as segmental myoclonus and spinal.
They're usually those with the PMEs, which towards the even those who have got mitochondrial diseases, even towards the end,
yes,
when they regress at a certain stage, they do have this abdominal myoclonus, which are still originating from the spinal cord. I mean, some of the theories is because of the release of the central command or central control to the spinal motor neuron leads to these autonomous discharges, of course, superadded by the irritability of the nerves because the degenerating nature of the axons. So that is some of the explanation given. Even in mitochondrial disease, you do see that in some of the PMEs. Yes, I do agree. But usually you tend to see them in the certain stage, which are, as they have regressed to a certain stage, when they're probably bed bound or they're not that much functional, you tend to see that. Yeah.
Thank you. So thank you, Dr. Fazil and Dr. Akash and Dr. Gautam for that.
Just to add to that, ma'am, the spine MRI was done, which was normal as such. So we actually had suspected there could be some spine pathology, but nothing was found.
There was no spine localization per se. And also, I have seen one intractable hiccup with brainstem tuberculoma, very, very focal. So it presented like hiccups, nothing else. And MRI showed up with small tuberculoma, which was in the brainstem. So that is also something which we have to keep in mind because NCC tuberculoma, they can have any localization and such focal presentation. Yeah. Moving on to the last case, that is the fifth, and hopefully we are keeping up to the time. So this comes from CMC Vellore, and Dr. Sangeeta Yoganathan is the moderator for the case, and Dr. Sridhar will be presenter. So over to you, Dr. Sridhar.
Presenting the last case of the day. The case is usually a spotter for most of us, but the complication which is there in the case is a bit unusual and a challenge. So I'll be presenting an adolescent boy with twisted postures and stormy pores. So Master Y, a 10-year and 4-month-old male child, first and only born child to non-consanguineously married parents, presented to us with history of tremulousness of limbs while reaching out for objects and abnormal twisting postures of both upper limbs in January 2021. In the first week of January, the disease started as a left focal facial spasm with preserved awareness and intermittent siluria. And in second week, it progressed to involve both the upper limbs in form of tremulousness while reaching for objects. And parents also noticed abnormal twisting postures of bilateral upper limb when the child was walking. In February, the child developed slowness in all the activities of daily living, had difficulty in grasping objects with hand because of twisting postures, and had deterioration of handwriting in form of micrographia. And in March, he had oromotor dysfunction characterized by chewing difficulty, requiring manipulation of food bolus in the mouth, and also required gravity and water-assisted swallowing at the end of the month, associated with intermittent coughing and choking on feeds. On retrospect, we also found history of emotional lability, adamancy, temper tantrums, and intermittent anger outbursts since January 2021. The antenatal history was uneventful except a bleeding per vaginum in the first trimester, which was treated with weekly parenteral medications. He was born full-term by vaginal delivery with a birth weight of 2.5 kg and had cried immediately after birth and had pre-morbid typical development with average scholastic performance and ADL independence. However, there is a history of jaundice lasting for 10 days in October 2019 without any localizing symptoms. So on examination, the child was anxious and had emotional lability. The anthropometric parameters were age appropriate. On general physical examination, he had a vacuous bile. The bilateral Kesha-Fleischer rings were visible and had anterior siluria with rigid dysarthria and hypophonia. On neurological examination, there were no cranial deficits, and motor system examination revealed abnormal twisting postures of both upper limbs with bilateral striatal toe, just localizing it to extrapyramidal involvement. On investigations, hemogram was normal with a slight low normal thrombocytopenia with elevated retic count and mildly elevated AST. However, the Coombs test was negative and the urine protein creatinine ratio was normal. Because of Kesha-Fleischer ring, we directly investigated for Wilson's disease, in which we had low serum copper and serum celloplasmin and elevated 24 hours urine copper. For dystonia, we did a CPK and urine myoglobin, where CPK was mildly elevated and urine myoglobin was negative. And a USG abdomen showed a coarse ecotexture of liver parenchyma with surface irregularity, pointing to hepatic involvement. Coming to neuroimaging, MRI brain revealed T2 and flare symmetrical hyperintensities in bilateral corpus striatum with hypointensities in T1 images and an element of both restricted as well as facilitated diffusion in DWI and ADC and a blooming in bilateral globus pallidus. So in March 2021, when the child presented to us with the diagnosis of Wilson's disease, we started the child on chelation by zinc, and 2 weeks later, we started D-penicillamine chelation. We started with a low dose of 250 milligram alternative for first 2 weeks and followed by 250 milligram daily to continue. And the dystonia was managed with polypharmacy of multiple anti-dystonia medications, as mentioned. However, in April, after 3 weeks of initiation of D-penicillamine, and in spite of a slow escalation, the child had worsening of dystonia. Now the dystonia also involved trunk and neck in form of retrocollis and opisthotonus, and the child became non-ambulatory. And in May, 2 months later, the child got admitted with status dystonicus. So this is the video of the child after worsening after D-penicillamine. We can see the abnormal twisting postures of both the upper limbs, the spasmodic contractions of the thigh muscles, and the wincing cry of the child. This was near continuous throughout the day and was hampering with the sleep of the child. It was really distressing the child as well as the parents. We can hear the wincing cry of the child, the spasmodic contractions, and it was really very painful for the child. And this was on combination of 5 antidystonic medications. So apart from the 5 antidystonic medications whose doses were optimized, we also gave botulinum toxin to the child in various groups to relieve the pain, and extracorporeal shockwave therapy was also initiated in consultation with pain medicine. Dis-penicillamine was stopped and triantine initiated and gradually escalated as D-penicillamine related worsening was suspected. Zinc was continued. The child was continued on a low copper diet via nasogastric tube. And this is the child on this management, where we can see almost 1 year later, the child being still on nasogastric tube, but now is ambulatory. And almost 2 years later, he is now completely independent for his activities of daily living. So this was a rather simple case of Wilson's disease, neurological and hepatic involvement, but had a complication of status dystonicus, which was related to dis-penicillamine initiation. So Wilson's disease, as we know, is an autosomal recessive disorder characterized by mutation in ATP7B gene, which codes for a copper transporting P-type ATPase, which has a two-pronged function. First, the conversion of apoceruloplasmin into holoceruloplasmin for transport of copper in the circulation and excretion of copper in bile. When deficient, copper builds up in the hepatocytes, causing hepatic injury, and then leaches into circulation and gets deposited in various organs to cause a multisystemic involvement, as is demonstrated by the species slide. There is a good clinical tool which can help clinicians in diagnosis of Wilson's disease. And we can see that even without the genetic testing and liver biopsy, if the score is more than 4, then the diagnosis of Wilson's disease can be clinically established. In our case, the score was 10. So coming to management, the goals of management are to decrease the copper intake, which is attained by low copper diet, chelate copper using copper chelators like zinc, D-penicillamine, and trientine, and to manage the comorbidities associated with the condition. So for copper chelation, D-penicillamine can be used at a dose of 20 mg per kg per day in 2 to 3 divided doses and should be taken either 1 hour before or 2 hours after meals, and should always be supplemented with pyridoxine. Zinc can be used at a dose of 25 mg TID if it is the weight is less than 50 kg, and it could be taken, the zinc and D-penicillamine should be at least 1 hour apart. And trientine is also a copper chelator which can be used as similar dose as that of D-penicillamine in these children. A word about status dystonicus. It's a life-threatening movement disorder emergency. The term coined as dystonic storm by Jankovic and Penn, characterized by increasingly frequent and severe episodes of generalized dystonia requiring urgent hospital admission. A multitude of etiologies can cause status dystonicus, and they usually affect the motor generators or modulators along the craniospinal axis. And this is usually precipitated by infection or medication withdrawal or the primary pathology itself. And in severe cases, it can cause severe exhaustion and pain, which can lead to life-threatening metabolic derangements and cardiorespiratory compromise. So this is a basic pathophysiology of a movement disorder storm. And here we can see that all the craniospinal generators or motor modulators are involved. And that D-penicillamine mediated status dystonicus is usually brainstem mediated phenomenology because of decoupling caused by D-penicillamine in Wilson's disease. So coming to the natural history of dystonic storm. So a child who has a stable dystonia by a trigger, let's say an infection or a medication withdrawal, or let's say introduction of D-penicillamine in Wilson's disease, leads to a dystonic storm. And once it is treated, there could be a gradual recovery and may or may not return to the baseline. So this may take around weeks to months in a child. So a simplified management option for...
I would request
yes.
to wind up.
Yes, ma'am. So the simplified scheme would be to classify these patients as per dystonia severity action plan into grade 1, 2, and 3, in which we only require medications to be adjusted, whereas grade 4 and 5, as seen in our case, they have metabolic disturbances with dehydration and hypercemia, which should be managed with intravenous medications. So in our child, this is a simple algorithm in which grade up to grade 2 can be managed with uptitration of medications. Grade 3 will require polypharmacy with anti-dystonia medications, and grade 4 and 5 will require intravenous midazolam and may require intubation, ketamine, and non-depolarizing neuromuscular agents. This is our case series of a decade which we published in last June. And in this case series also, the most common cause of pre-status and status dystonicus was Wilson's disease. So take-home message being, it's a early clinical diagnosis to be made, and modified Leipzig score can be used. Really simple diagnosis. Management relies on low copper diet and copper chelators, but we need to start low and go very, very slow. Screen for systemic complications of copper leaching. Status dystonicus is a movement disorder emergency, and we need to treat the precipitating factors as well as to consider aggressive anti-dystonia measures. And majority of patients requires months to years to get treated. So have lots and lots of patients. Thank you.
So thank you, Dr. Sridhar. I would request Dr. Sangeeta to have final words and comments on the case, and also timing, if there is any role, because I did not see it on the presentation part. And Dr. Naveen has also joined, so maybe after that, Dr. Naveen, we can hear from him.
Thanks, Dr. Sridhar, for the nice presentation. Status dystonicus is one of the rare and dreaded complications seen in children with Wilson's disease. So, structured protocol-based management with antidystonic medications, along with addressing of the precipitating factors, will improve the long-term outcomes. So, it will always reduce the morbidity and mortality. So in most of the centers, depenselamine is the commonly used first-line chelator along with the copper-restricted diet and zinc therapy. Trientine may be considered in children if they have a depenselamine-related neurological worsening, if they are affordable. We had a study from our center among 122 patients with Wilson's disease who had started on depenselamine. About nearly 25% had worsening following depenselamine therapy, and few of them were kept only on zinc monotherapy. Among 27 children who had worsening, 15 were kept only on zinc monotherapy along with copper-restricted diet. And all of them had shown a good improvement. So if the patients are unaffordable, zinc monotherapy with copper-restricted diet has also been found to be beneficial. So I'd like to hear comments from experts. Thank you.
Thank you. So, Dr. Naveen, sir, he's there because most of the big institutes have a lot of experience with Wilson's disease. And also, as I was questioning on thiamine, so Dr. Sangeeta and Dr. Naveen, if you can.
Yeah, thiamine, I think it's an off-label use. We have also tried in few patients who had worsening with depenselamine. So have found to have some stabilization, but we really do not know whether to attribute to the thiamine solely to the improvement or to the other medication modifications.
Right. Thank you.
I would echo what Dr. Sangeeta has said. So basically, apart from thiamine, if there is a worsening, we will try riboflavin and coenzyme Q and some of the antimitochondrial drugs for a brief while, just for 2 to 4 weeks initially, thinking that maybe the excess copper has caused secondary mitochondrial injury. So since it's an innocuous therapy, we try it in patients in whom we have drug-related or otherwise disease-related severe manifestations. The important thing in this case was that the patient had a very severe initial course, and then we see the follow-up, which is very heartening to see. So one question from Dr. Sangeeta is, among the 18 patients with Wilson's who had status dystonicus, what was the outcome in the other patients? Was it always, or at least in
No,
what
no,
proportion?
sir. Among 122 patients, 27 had worsening. So 15 were put on only zinc monotherapy. 4 patients was managed with a combination of zinc and trientine. Whoever could afford for trientine, we started on trientine. Along with the copper restricted diet, we continued zinc as well. 5 patients were managed with trientine alone. And re-challenging with depenselamine at a low dose and followed by slow dose escalation, we attempted in 3 cases. So gradual clinical and functional status improvement was observed over 1 to 2 years. It's not like drastic improvement in a short span of time. So was observed in 24 cases, but one child succumbed to pneumonia during the acute phase with status dystonicus. The child succumbed to pneumonia. 2 patients were left with deficits.
No, my question was from your other series in which you had status dystonicus, and within
Yeah,
the status dystonicus, you had Wilson's disease. So among those with Wilson's and status dystonicus, because our experience has not been very good with those who come with.
So, sir, majority of them do persist of residual dystonia, but they do achieve ambulation. So they are not non-ambulatory after status dystonicus. So in our series also we used the modified ranking scoring. So majority were 1 or 2 in them. So we had 13 patients, and of them 8 were achieved MRS2.
Because your last line in your slide was very important. So when you have this kind of patient, what I have seen is their improvement then runs into several months and years. So the average time we give to parents is 1 to 2 years by the time you'll start seeing improvement, particularly when they are so severe in the acute phase. And also to caution that, similar worsening can also be seen with trientine. And it's not just penicillamine. Trientine is also known to be associated with disease-related worsening. And we have certainly not seen the 50% worsening rate that is reported in literature with penicillamine. It is much lower than that, probably closer to 20-25%, as Dr. Sangeeta has put. That's all from my side.
Thank you so much. So very, very interesting and very important inputs, as Wilson's disease still remains something which we see so often, remains treatable. But yes, a lot of patients and not as quick in terms of treatability. So we have heard from all of them. I can see the chat box like question and answers, and one is for Dr. Sangeeta and Dr. Sridhar. What is the extracorporeal shock therapy for the last case? So if Dr. Sridhar can comment on that.
So basically, it's a ultrasound-based therapy. They give ultrasound waves over the muscles, which can decrease the pain over the muscles. They may sometimes be heat-based therapy, sometimes maybe cold-based. So we have a pain medicine team, which we usually call upon, and they do give these therapies. But the major, even with botulinum toxin and this therapy, the child was in severe pain for let's say 2 to 3 months. So it did not make much of a difference. But yeah, we tried desperately for this child. Usually for generalized dystonia, we don't even advocate botulinum toxin. But some of the muscles were so severely dystonic, and the child, it was hampering with the child's sleep, that we decided to give Botox to selected group of muscles. And we also tried this shockwave therapy, but to no avail. So it was not that improvement in the child acutely. It took months for this child to come to baseline.
Dr. Tajul wants to make a comment, so he's raised his hands. Let's see what he has to say. Dr. Tajul, please.
Thank you very much. Dr. Sridhar, would you be able to play the video again?
Dr. Sridhar.
Sure, sir. Sure, sir.
Meanwhile, for the case 3 for Dr. Gautam, any finding on retina, and were the steroids given in the third case? So you can be ready with those answers. Yes.
Sir, the dystonia video, no?
Yes.
Yes, dystonia video.
I hope my screen is visible.
Yes.
And how high was the CK?
CK at this time was less than 1,000. Exact value I don't remember, but it was less than 1,000.
So I mean, I'm not going to comment much about Wilson disease because I've got very limited experience on that. But looking at the phenomenology itself, so this phenomenology would better fit on hypokinetic rigid syndrome rather than dystonia. So for us to denote any child or any movement phenomenology as dystonia would be something that must be very repetitive movement, can be jerky at times with twisted posturing. So this characteristic should be there for us to call this as dystonia. So what this child has got is the child has got
This,
evidence of.
We can see the twisted postures in the upper rim, sir. The left
Yes,
hand, if you
in
can.
in the upper limb, yes, but not in the lower limb. So what you actually see in the lower limb is the co-contraction of agonist and antagonistic muscle, absence of twisted posturing, absence of repetitive movement with some tremulous movement. So when you see a child with tremor, dystonic tremors are very rare, but rigidity with tremors are more common than dystonic tremors. So the moment you see a tremor superimposed on a certain phenomenology, it'll be easier to diagnose or suspect rigidity rather than a dystonia first, because the upper limb, as you can see, the hand shows dystonic posturing, whereas the lower limb doesn't have dystonic posturing. Second, in status dystonicus, in majority of the cases that I've seen and I've managed, your CK is in the 5 figures, or at least higher 4 figures, 6,000, 7,000, 8,000, especially in a child who has got very good muscle bulk such as this. Unlike in certain cerebral palsy children who have got spasticity with dystonia and their muscle bulk is so poor, the CK doesn't climb up too high and if they're well hydrated. And with the tremor, the tremorless movement, and with very mild bradykinesia, as you can see when the child is moving, the what you call the speed of the movement is kind of slightly slow and slightly restricted. So there will be probably some nature of bradykinesia there with rigidity. So I would, this would best fit on hyperkinetic rigid movement or rigid syndrome. Of course, the upper limb that you can see and the back is dystonic posturing. Thank you.
Thank you so much. So Dr. Sangeeta has to say anything after this.
No. Actually, this child had predominant dystonia at presentation, and he also had a generalized dystonia at presentation with opistotonic posturing, and even he had a laryngeal stridor as well. So I think there were more videos to it which Sridhar couldn't capture, but the current video, as Dr. Tajul was mentioning, like upper limb, the dystonia is predominant, and the lower limb, it is not very well evident.
Right. Great. So very nice. I mean, all the presentations, all the cases, moderators and discussants. We are through this session.
Rachna?
Yes, sir.
Rachna, we end before ending. The experts and the moderator has to give some final take-home message. So, so
Yeah,
Naveen had to leave. Naveen
yes.
has left. Yeah.
And
Taj, Dr. Tajul,
yes, he's
take-home message.
Good presentation, and recognizing the phenomenology clearly would be probably of paramount importance. We should recognize the phenomenology clearly so that would help us to guide us in which direction that we go and how we are making a diagnosis of certain syndrome. That will be my take-home message. Thank you.
and
Dr. Thank you so much.
Dr. Mahesh and ma'am, yes.
You.
We had
After Mahesh, you.
interesting cases. One comment, in the last almost decade or so, I'm not using any other drug other than zinc for managing durable cells. And I got almost more than 4 or 5 cases. All of them I'm able to manage only with zinc. It takes around a couple of months, but with just zinc alone, most of patients are doing well. So it has become my practice that I don't use any drug other than zinc to manage durable cells. And so far, I have not failed in any case. Initial a few years, I had a very bad experience with D-pen, so I stopped using D-pen, and only zinc I got very good results with treating neural cells. Otherwise, all other cases very nice.
Rachna?
That is, I was just going through the question and answer if anything got added. Not really, we covered everything. For Dr. Gautam's case, there were 2 things, like they were asking for the third case, how was retina and were steroids used in the third case? So Dr. Gautam and Dr. Akash, if they are there.
Gautam? Meanwhile, you can give take-home message and Sangeeta also.
Dr. Sangeeta, to wind up and the final comments.
So I think movement disorder is a very important topic in the pediatric neurology, and understanding the phenomenology and identification of the underlying movement disorder along with the etiology workup will help to improve the outcome. So any child presenting with, as I already was mentioning, a child presenting with an unexplained movement disorder, particularly at the end of first decade or later, we shouldn't miss out Wilson's disease. And there are many more treatable disorders which are being diagnosed nowadays with the advent of genetic testing. So it is important to always have a clinical diagnosis, and then along with the corroborative evidence from the genetic testing, it will improve the long-term neurological outcome. Thank you.
Thank you, Dr. Sangeeta. I agree totally. The first thing with the movement disorder is analyzing them again and again, trying to find out which are the key movements involved. And also one thing which got sort of missed out in our series is the genetic part of it. And most of our cases were more acquired, and other than the Wilson's, of course, which is also genetic. So final words from Dr. Shefali ma'am, and and finally we wind up.
Rachna, Akash is there. Ask Akash the question, please. Akash.
For the third case, There is a question in the Q&A that was the retina checked? 1, and number 2, steroids were used for the case 3.
Fundus was checked. It was normal.
It's normal, yes.
Yeah, ma'am. Otherwise, IVIG the child had gotten empirically, but by that time that autoimmune encephalitis report had come, so he was not given steroids.
Not given steroids. Okay.
Yes.
Okay. So everything
Thank you.
else.
Yeah, I think everybody's made a lot of wonderful presentations, and especially Ranjit's MBBS resident. I think I must, it's really appreciate, and it's very nice to see all my students becoming great teachers. And I keep feeling ancient when I see. And thank you all for joining. And on 3rd of January, and may I say happy birthday to you, Rachna. Thank you so much for moderating. And thank you, Dr. Taj, for joining. And thank you so much. Everybody will be mailed their presentations and their certificates. And the movement disorder SIG was started in a rocking note and will continue rocking this month. Thank you, Rachna. Thank you so much.
Good night. Good night.
Right.
Good night. We can wind up right here. Thank you.